In today's session, we're exploring the femur. In this video, we'll cover the femur's unique position as the longest and strongest bone in the body, its anatomical parts, upper end, shaft, and lower end, important muscle attachments, and blood supply. Key clinical notes you need to remember for exams and practice. Let's get started. The femur, or thigh bone, is the longest and the strongest bone of the body. Like any other long bone, it has two ends, upper and lower, and a shaft. Side determination. The upper end bears a rounded head, whereas the lower end is widely expanded to form two large condyles. The head is directed medially. The cylindrical shaft is convex forwards. Upper end. The upper end of the femur includes the head, the neck, the greater trochanter, the lesser trochanter, intertrochanteric line, and the intertrochanteric crest. These are described as follows. Head. The head forms more than half a sphere and is directed medially, upwards, and slightly forwards. It articulates with the acetabulum to form the hip joint. A roughened pit is situated just below and behind the center of the head. This pit is called the fovea. Blood supply. The smaller medial part of the head, near the fovea, is supplied by medial epiphyseal arteries, derived from the posterior division of the obturator artery and from the ascending branch of the medial circumflex femoral artery. The larger lateral part of the head is supplied by lateral epiphyseal arteries, which are derived from the retinacular branches of the medial circumflex femoral artery. Neck. It connects the head with the shaft and is about 3.7 centimeters long. It makes an angle with the shaft. The neck shaft angle is about 125 degrees in adults. It is strengthened by a thickening of bone called the calcar femoral, present along its concavity. The neck has two borders and two surfaces. The upper border is concave and horizontal, meets the shaft at the greater trochanter. The lower border is straight and oblique, meets the shaft near the lesser trochanter. The anterior surface is flat. It meets the shaft at the intertrochanteric line. The angle of femoral torsion, or angle of anteversion, is formed between the transverse axes of the upper and lower ends of the femur. It is about 15 degrees. Blood supply. The intracapsular part of the neck is supplied by the retinacular arteries. The vessels produce longitudinal grooves and foramina, mainly on the anterior and posterior superior surfaces, The extracapsular part of the neck is supplied by the ascending branch of the medial circumflex femoral artery. Greater trochanter. This is large quadrangular prominence located at the upper part of the junction of the neck with the shaft. The upper border of the trochanter lies towards the level of center of head. The greater trochanter has an upper border with apex. The anterior surface is rough in its lateral part. The medial surface presents a rough impression above and a deep trochanteric fossa below. Lesser trochanter. It is a conical eminence directed medially and backwards from the junction of the postero-inferior part of the neck with the shaft. Intertrochanteric line. It marks the junction of the anterior surface of the neck with the shaft of the femur. It is a prominent roughened ridge which begins above at the antero-superior angle of the greater trochanter as a tubercle and is continuous below with the spiral line in front of the lesser trochanter. Intertrochanteric crest. It marks the junction of the posterior surface of the neck with the shaft of the femur. It is a smooth, rounded ridge which begins above at the postero-superior angle of the greater trochanter and ends at the lesser trochanter. Shaft. The shaft is more or less cylindrical. It is narrowest in the middle and is more expanded inferiorly than superiorly. It is convex forwards and is directed obliquely downwards and medially because the upper ends of two femora are separated by the width of the pelvis, and their lower ends are close together. In the middle 1/3, the shaft has three borders: medial, lateral, and posterior, and three surfaces: anterior, medial, and lateral. The medial and lateral borders are rounded and ill-defined, but the posterior border is in the form of a broad, roughened ridge called the linea aspera. The linea aspera has distinct medial and lateral lips. In the upper 1/3 of the shaft, the two lips of the linea aspera diverge to enclose an additional posterior surface. In the lower 1/3 of the shaft also, the two lips of the linea aspera diverge as supracondylar lines to enclose an additional popliteal surface. Lower end. The lower end of the femur is widely expanded to form two large condyles, one medial and one lateral. Anteriorly, the two condyles are united and are in line with the front of the shaft. Posteriorly, they are separated by a deep gap termed the intercondylar fossa or intercondylar notch. Lateral condyle. The lateral condyle is flat laterally and is more in line with the shaft. It, therefore, takes greater part in the transmission of body weight to the tibia. Medial condyle. This condyle is convex medially. The most prominent point on it is called the medial epicondyle, intercondylar fossa, or intercondylar notch. This notch separates the lower and posterior parts of the two condyles. It is limited anteriorly by the patellar articular surface and posteriorly by the intercondylar line, which separates the notch from the popliteal surface. The following are attached to the greater trochanter. The piriformis is inserted into the apex. The gluteus minimus is inserted into the rough lateral part of the anterior surface. The obturator internus and the two gemellae are inserted into the upper rough impression on the medial surface. The obturator externus is inserted into the trochanteric fossa. The gluteus medius is inserted into the ridge on the lateral surface. The attachments on the lesser trochanter are as follows. The psoas major is inserted on the apex and medial part of the rough anterior surface. The iliacus is inserted on the anterior surface of the base of the lesser trochanter and on the area below it. The intertrochanteric line provides attachment to the capsular ligament of the hip joint, attachment to the upper band of the iliofemoral ligament in its upper part, attachment to the lower band of the iliofemoral ligament in its lower part, origin to the highest fibers of the vastus lateralis. From the upper end, and origin to the highest fibers of the vastus medialis. From the lower end of the line. The quadrate tubercle receives the insertion of the quadratus femoris. The attachments on the shaft are as follows. The medial and popliteal surfaces are bare, except for a little extension of the origin of the medial head of the gastrocnemius to the popliteal surface. The vastus intermedium arises from the upper 3/4 of the anterior and lateral surfaces. The articularis genu arises just below the vastus intermedius. The lower 5 centimeters of the anterior surface are related to suprapatellar bursa. The vastus lateralis arises from the upper part of the intertrochanteric line, anterior and inferior borders of the greater trochanter, and the upper half of the lateral lip of the linea aspera. The vastus medialis arises from the lower part of the intertrochanteric line, the spiral line, the medial lip of the linea aspera, and the upper 1/4 of the medial supracondylar line. The deeper fibers of the lower half of the gluteus maximus are inserted into the gluteal tuberosity. The adductor longus is inserted along the medial lip of the linea aspera. The adductor brevis is inserted into a line extending from the lesser trochanter to the upper part of the linea aspera. The adductor magnus is inserted into the medial margin of the gluteal tuberosity, the linea aspera, the medial supracondylar line, and the adductor tubercle. The pectineus is inserted on a line extending from the lesser trochanter to the linea aspera. The short head of biceps femoris arises from the lateral lip of the linea aspera, the lower end of the lateral supracondylar lines gives origin to plantar. The attachments on the lateral condyle are as follows. The fibula collateral ligament of the knee joint is attached to the lateral epicondyle. The popliteus arises from the deep anterior part of the popliteal groove. The muscular impression near the lateral epicondyle gives origin to the lateral head of the gastrocnemius. The attachments on the medial condyle are as follows. The adductor tubercle receives the insertion of the hamstring part or the ischial head of the adductor magnus. The tibial collateral ligament of the knee joint is attached to the medial epicondyle. The attachments on the intercondylar notch are as follows. The anterior cruciate ligament is attached to the posterior part of the medial surface of the lateral condyle on a smooth impression. The posterior cruciate ligament is attached to the anterior part of the lateral surface of the medial condyle on a smooth impression. The intercondylar line provides attachment to the capsular ligament and laterally to the oblique popliteal ligament. Ossification. The femur ossifies from one primary and 4 secondary centers. The primary center for the shaft appears in the 7th week of intrauterine life. The secondary centers are one for the lower end at the end of the 9th month of intrauterine life, one for the head during the first 6 months of life, one for the greater trochanter during the 4th year, and one for the lesser trochanter during the 12th year. There are 3 epiphyses at the upper end and 1 epiphysis at the lower end. The upper epiphyses, lesser trochanter, greater trochanter, and head, in that order, fuse with the shaft at about 18 years. The lower epiphysis fuses by the 20th year. Clinical anatomy. Tripping over minor obstructions or other accidents causing forced medial rotation of the thigh and the leg during the fall results in spiral fracture of the shaft of the femur in persons below the age of 16 years. Bucket handle tear of the medial meniscus between the ages of 14 and 40 years. Fracture of the neck of the femur over the age of 60 years. That's the femur, strong, vital, and clinically important. In the next lesson, we will see another fascinating part of the human body. Thanks for watching.